Well, good morning, everybody. Cardiovascular Pharmacology Part 4. Wow, can you believe it? Okay, so we're going to move forward. You know the drill here. If I only knew how to advance the slides while recording it, I'll go really fast. Hey, that'll work. Let's see, we did that. Yeah, nitrates. Yeah, we did that. Yeah, oh boy. Oh, God, we don't want to hear that. Okay, here we go. So thromboembolic disease. When we're talking about thromboembolic disease, we want to know the difference between coagulation and hypercoagulation. Coagulation is what happens when you cut yourself. You know, there's a break in the blood vessel from the outside world to the inside world, and blood is escaping. That's good. We like coagulation. Hypercoagulation, not so much. That's the formation of a clot within a blood vessel that is undamaged. And that happens from lots of things. It could happen from the plaques of cholesterol making the inside surface of the blood vessel rough and having the platelets stick to it. Could be the platelets stick together because the vein collapses and then blood stands still. It could be an atrial fibrillation where there's a moment where the atria and the ventricles are not in sync and blood stands still for a moment, and you guessed it, another clot forms. So we're worried about hypercoagulation because of the formation of these thrombi, which now may block another blood vessel down the line. For that reason, we will use two different kinds of drugs, an antiplatelet agent and an anticoagulant. Well, what's the difference between the two? Well, antiplatelet agents like aspirin, Plavix, Effient, Brilinta, they're designed specifically for what it sounds like. They make your platelets less sticky and therefore less likely to stick together to form a thrombus. But be advised, my friends, these are not anticoagulants. They do nothing to affect clotting factors. So they're useful in preventing cardiovascular events, acute coronary syndrome, or sometimes also known as atrial fibrillation. Or maybe you've had a recent MI or a stroke and you want to prevent another one. Or also maybe you've had stents placed, these little spring things that keep your arteries open. You can have them implanted when you've got a serious blockage and they can't do a bypass. Well, lots to talk about, but let's put it this way. Are there drug interactions? Yes. But the issue has always been with antiplatelet agents, is there an increased risk of bleeding? Yes. Would there be other drugs in dentistry that would make that risk of bleeding worse? Yes, and we'll talk about these the rest of the semester. Non-steroidal anti-inflammatory agents do a good job in making your platelets less sticky on their own. Antibiotics and the effect on the microflora and vitamin K production. But my bottom line here, literally and figuratively on this slide, is do you tell a patient to stop using an antiplatelet agent prior to a dental appointment? And all of the literature suggests that the answer is no. We keep the patient on the anticoagulant and we work around the bleeding, because stopping the anticoagulant, or in this case the antiplatelet agent, will cause the patient to be at unnecessary risk for thrombosis. So, no stopping antiplatelet agents, no stopping anticoagulants. And for the record, my friends, it's really not our decision anyway. As a hygienist, that decision falls squarely on either the dentist's shoulders or, more likely, the cardiologist's shoulders. Okay, well then let's talk about oral anticoagulant agents. Again, what's the difference? What do you say? Interesting.
I don't know.
Yeah, that's about what I know. Just kidding, folks. Well, okay. Let's start off with the classic, right? Coumadin, the all-time favorite anticoagulant. Everybody knows warfarin. And now Coumadin inhibits the synthesis of vitamin K-dependent clotting factors. This is huge because this points to the one thing that makes Coumadin so lovable, and that is vitamin K. If I want to reverse the effect of Coumadin, I'm experiencing an exaggerated response to Coumadin because I have something else going on. I took a dose of aspirin, or maybe my dose of Coumadin just wasn't right. I can take a dose of vitamin K and reverse the effect. Now you might think, well, so what? It's an antidote. As you'll see in this class of medications, antidotes are hard to come by. So you'll notice Coumadin kind of has the same indications that the antiplatelet agents have, prevention and treatment, a little different, of thrombosis. So if you're on Coumadin, you've had the big event. We're not so much in prevention mode as we're in preventing and treating mode. Again, atrial fibrillation, prosthesis like prosthetic heart valves, or perhaps, again, we said things that are placed in your veins like stents, or arteries. Even a recent MI makes you a candidate for Coumadin therapy. Well, the one thing I love about Coumadin, I think everybody loves about Coumadin, is the fact that it's assessed by what we call the INR, the International Normalized Ratio. And the INR tells us in a number if the patient is too anticoagulated or not anticoagulated enough. Now that's good because numbers work for us, right? Pretty much black and white. The problem is getting the patient to get the blood work done. It's got to be done typically every 2 weeks. And that means, lifestyle impingement. People don't like it. They'd rather not do it. Some people, and by the way, there's no Coumadin police. So nobody can force you to go to get this blood test. So as a result, after, maybe about a year or two of therapy, a lot of people stop getting it done. Risky, because they really do need to know their INR for their own purposes to see if their dose of Coumadin is correct, but also for our purposes to make sure it's okay to work on them. But again, lifestyle impingement, a lot of people decide, it's not worth it. My advice, ask every time. Even if they don't have it, you ask, because that way you can document such in the chart. And for the record, a value of 1 is considered normal for an INR. Some people push it to 2, but it needs to be at least 3.5. If it's greater than 3.5, you have the right to tell the patient, I can't treat you today. Of course, when talking about INR, people get really upset. And they get pretty upset and they start to whine. Like, I don't want to go for my blood work. Why should I go for my blood work? What do you say to these people?
Stop whining.
That's right. Stop whining and get your number. Okay. The anticoagulant effect of Coumadin can be reversed with vitamin K, as we said. This is good. However, does this still pose a risk of bleeding if you were to combine it with drugs used in dentistry like NSAIDs and antibiotics? Yes. And again, do we tell a patient to stop using Coumadin prior to a dental procedure? No. Well, this all changed with the introduction of Pradaxa. Pradaxa is an anticoagulant that doesn't follow the rules that Coumadin follows. It doesn't work on vitamin K dependent clotting factors. It works on one single factor, thrombin. This means a great deal for this drug. So while it's used for sort of the same thing that Coumadin is used for, prevention and treatment of thrombosis, the biggest difference with Pradaxa is there is no INR test required. The INR test doesn't work because the INR measures vitamin K clotting factors, and this anticoagulant doesn't work on vitamin K clotting factors. So no INR means, no routine blood work necessary. And your patient says,
Oh, yeah!
I'm going to believe it. But you say, no, what do you mean no INR? Right. So do you know if it's safe to work on the patient? No. One more note for you folks, and I'm glad you're listening to this while you're looking at your handout. At the top there it says no antidote for reversal. This was true up until about 6 months ago. Now there is a reversal agent, so I'm going to ask you to write it down on your slide while we're here. It's in my opinion, the best way to learn something is to write it down and make it stick in your memory. So here it comes, okay? The name of the reversal agent is Praxbind. I'll spell it for you. Praxbind. Praxbind. New, as I said, not something you're going to find in your freezer like a frozen block of spinach, which has vitamin K. You need to get to the hospital to get it. But it is the latest breakthrough in Pradaxa therapy because now we have an antidote. Okay, any other issues with Pradaxa? Yep, some people get upset stomach. Yeah, that's not good. But my issue with Pradaxa is the same as we've said before. There's an increased risk of bleeding with the drugs we use in dentistry, right? Again, NSAIDs and antibiotics. And let's face it, I'm not going to tell a patient to stop using their Pradaxa prior to a dental treatment. Okay, now we have Xarelto and another anticoagulant, which again I'm going to ask you to write in because it's new and board exams love to focus on new things. So you have Xarelto, and then the next one I need you to write in is Eliquis. 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 Now these two anticoagulants work very well because, again, they block a particular factor. Now, not thrombin like before. This is factor 10A, often referred to as XA, and now you can see where Xarelto gets its brand name from, right? First two letters are XA. So we see the prevention and treatment of thrombosis, same as we saw before. What's the big deal about Xarelto and Eliquis? You know it. No INR testing, since they work on factor 10A and not more other vitamin K clotting factors. These two drugs are not INR dependent, so you can't get an INR test done. And if you did get it done, it still wouldn't work because you need the INR test to measure vitamin K dependent clotting factors, and these are not. So, no INR testing. What does your patient say to that? You know.
Oh, yeah!
You say, oh, no INR. How do I know if it's safe to work on the patient? You don't. You might think this is crazy. Like I'm the first one to tell you this, and I probably am the first one to tell you this, but ask your doctor when you get to work or ask someone in the clinic, one of the faculty members, and they will tell you, this is pretty scary stuff. There's no INR for these drugs. There's no way to test to tell if these drugs are working too well or not well enough. There's no way to tell if it's safe to work on a patient. So you've got to go with the cardiology consult, as always. The other thing about these drugs is there's no antidote for the reversal of the anticoagulant effect. So, unlike Pradaxa, which just got its antidote, Praxbind, and unlike Coumadin that always had an antidote, vitamin K, these two drugs, Xarelto and Eliquis, do not have an antidote. And that means if you get into a major car accident, if you suffer internal injuries from a fall downstairs or something, there's no way to stop internal bleeding. Pretty scary. All right, so issues with these drugs? A few things. Okay, renal failure. I would go along with that. My issues again. Is there an increased risk of bleeding with other drugs that we use in dentistry? Yes. NSAIDs, antibiotics. We've already talked about it. Do you tell a patient to stop using their Xarelto or Eliquis prior to a dental treatment? Absolutely not. So we've answered some questions and are left with other questions to ponder. Meaning, what do we do when we don't have an INR? And the answer, of course, is always go with the cardiology consult. But what about cardiac arrhythmia? Heard a lot about this recently and in a different way than you might expect. So lots of folks suffer from arrhythmias, and we said one of the major causes of arrhythmias is post-MI. They've had a myocardial infarction, there was scar tissue that formed, the scar tissue is not contractile, it doesn't conduct the impulses, so the patient is left with parts of their heart that are not talking to each other, and that results in this arrhythmia. Well, what's new? What have I heard recently? I've heard that most antiarrhythmic drugs that we used to rely on are gone. And that's mostly because people just can't tolerate them because of the side effects. Well, cardiac arrhythmia is bad. It's a malfunction of the conduction system, a disruption of the sinus rhythm. That means the heart can either be beating too fast or too slow. And that just means that the heart is not efficient in delivering oxygen. And as I said, I've seen many people survive heart attacks, survive myocardial infarctions, only to die later of the resulting arrhythmia. So there used to be a whole bunch of drugs to treat arrhythmia, and you can see them all on the right there. Sodium channel blockers, potassium channel blockers. No more. Calcium channel blockers, maybe a little. The big drug that we use now to treat cardiac arrhythmia, beta blockers, because beta blockers do such a good job in controlling heart rate and heart rhythm. And the best part for you is you already know about them. For the record, these were the drugs that we used to treat arrhythmia. Okay, we used to use amiodarone, and I think we still do in emergency medicine, but amiodarone kills a lot of people every year. Quinidine, gone. Flecainide, gone. Lidocaine, what's that doing there? Well, it's true. We use lidocaine to treat ventricular arrhythmia in an emergency medicine. So the same old lidocaine that you use as a dental local anesthetic agent, when used IV, can seriously affect the heart rate. And I hope you get that from this. This is why when you're injecting anesthetic, they always say, what? Always aspirate. Always make sure you're not injecting that lidocaine dental cartridge contents directly into a vein. Well, my friends, we're going to take a break here, and then we're going to talk about congestive heart failure and finish up our cardiovascular clinical conundrums. So if you're all still with me, and I hope you're not watching all of these at the same time because it is very overwhelming. Take your time going through these videos to make sure you get all of the details. And of course, if you have any questions, you could just reach out to me anytime with an email or a text message, and I'll be happy to answer any questions you have. Okay, my friends, I'll be back in a few.